So this is going to be a 3-part talk that's broken up throughout the day. So there's no way, I mean, this could be like a 2-day workshop just on the MicroSkills of intubation. The second thing is that my preferred method of intubation is standard geometry, not hyperangulated, and video is my number one. So video standard geometry is my plan A. Direct standard geometry is my plan B. So everything I'm going to talk about is in regards to standard geometry intubation, not hyperangulated. That is a separate talk. Now, up here, I have a bunch of different MicroSkills. This is not an all-encompassing list, but I think it's important that we think about each of the little micro skills that we do when it comes to intubation. This is true of anything, not just intubation, but if you think about any skill, any procedure, anything that you do in life, if you think about breaking it into its component parts and think of those as MicroSkills, the chance that you're going to be successful is how well you practice and how good you get at each of those components. The more of them you get down, the more likely you're going to be successful. The more of them you don't get down, the less likely you're going to be successful. And so I've tried to really break this down into the low-hanging fruits of intubating somebody like a boss successfully. So let's start with pre-oxygenation and apneic oxygenation. Now, I'll tell you what I do for all my intubations. So anybody who comes in who needs to be intubated, regardless of cause, get put on 15 liters nasal cannula. I wish I could get my hands on high flow. Otherwise, I'd use high flow for my nasal cannula, but it's impossible where I work. So they just get on 15 liters and then I use a second oxygen source and I put the patient on a non-rebreather and I turn that up to flush rate. And so what do I mean by flush rate? So we all have these little meters on the wall. And what I see a lot of people do, and I see this a lot, is they'll turn it up to the 15 and they'll stop. When I say flush rate, I mean you turn that valve all the way till it sounds like you're in a wind tunnel and it won't turn anymore. And most of those valves will get you to 30 to 45 liters of flow. So essentially what I'm telling you is 45 to 60 liters of flow is the way I start every intubation to pre-oxygenate them. Once I get this on, this is my first step. Patient shows up, I'm putting these things on them. Now I'm starting to get my RSI meds, I'm starting to get my suction, I'm starting to do all these things. In the meantime, all this is sitting on the patient. Now, by the time I'm ready, if I look at the monitor and I have not even achieved an oxygen saturation of 95%, and I will tell you, ideally, I want it to be at 99 or 100%. If I've achieved 95%, then I'm good to move forward with my intubation. If I haven't achieved 95%, I've already told you, I really like to try and get closer to 100%. Then you got to start thinking about shunt or dead space physiology in the lungs. And for those patients, flush rate oxygen alone isn't going to do it. You need some type of positive pressure ventilation. These patients need PEEP, positive end expiratory pressure. Now, I'm not going to rehash dead space versus shunt physiology, but the whole point is that you're trying to recruit a bunch of alveoli that are atelectatic, that are not involved in gas exchange, not the ones that are diseased. And that's why PEEP works when you do this. And so just as a reminder, your dead space is going to be things like a patient in shock for whatever reason that may be, or maybe like a PE. And then your shunt is going to be things that are like filling the alveoli, not letting gas exchange occur. Pneumonia, edema, blood, you name it. And so for these patients, I take off the non-rebreather, I keep them on the nasal cannula, and they get a bag valve mask with a PEEP valve, and that PEEP valve is turned to 15. Now, recently, the pre-oxy trial just got published. And if I could add something to this slide, it would be that if I have the time and I have the resources and the equipment, instead of the bag valve mask and a PEEP valve, I would rather use non-invasive ventilation for my pre-oxygenation if I'm thinking shunt or dead space, okay? I don't have that on the slide because the study came out recently, and in some of the environments I work at a lot of freestanding ERs, or if I'm responding to codes on the floor, sometimes I don't either have the time or I don't have the equipment to use non-invasive ventilation. So this is my next option, which I think is probably pretty close to equivalent, except it's a little more clunky. Non-invasive is going to give you an actual volume. You know what the patient's getting. With a bag valve mask, it's totally dependent on how you're bagging the patient in terms of what they're getting. For those of you who aren't familiar with the PEEP valve, it's just this thing some of them are blue, but it's red. and literally turn it all the way up to 20. I do mine at 15. I like 15 liters of nasal cannula. I like flush rate, and then I like 15 of PEEP valve. It just makes less things to remember. That's not based on any studies or evidence. And then this is why PEEP works. So this is from New England Journal of Medicine. This is a little video, and I believe these are rat lungs, might be rabbit lungs. And so they're bagging this patient at 0 of PEEP, and right now you're going to see them go up to 15. You see how all those alveoli that were just crunched down are now getting recruited? This is how this works. This is why if you're not getting to 95% with that much oxygen, this is why you need PEEP. This is why positive pressure ventilation works. And it's probably why the Pre-Oxy trial shows that non-invasive ventilation is better than just putting somebody on a face mask. So this is kind of my workflow of how I start all my intubations. And as I work through, if I'm not achieving what I need to get, remember that green arrow. In an ideal world, it's non-invasive ventilation, but in some environments, I don't have that luxury. So this is my second backup.
I hate to break in here, but if you are enjoying this lecture right now, then you want to check out the entire Resusx reunion filmed live in Philadelphia 2024. There are over 60 talks that you can watch on replay for life. Right now, we have a coupon that gets you 20% off that entire package. Again, 20% off to watch the entire conference for life. So if you're enjoying this video and you want to watch lots more, go to the link below and sign up. Now back to the video.
Now, for those who are or aren't using apneic oxygenation, what I will tell you, and I'll be very upfront about this, I think if you do a really good job with pre-oxygenation, apneic oxygenation is probably superfluous. But you have no way to predict what an airway is going to look like, or somebody vomiting or having to take longer. And so to me, it's like no cost, no harm, no cognitive load. Just slap the nasal cannula on them and stop quibbling about whether it works or it doesn't work. And so this trial, the Endow trial, was a randomized clinical trial of 200 people in the ED that were getting intubated. They got randomized to nasal cannula apneic oxygenation versus none. And their primary outcome was the mean lowest oxygen saturation. And you know what? They found no difference. And so people use this study as like, man, we should just abandon apneic oxygenation. But there's a few details you need to really understand. The first is, on average, patients were pre-oxygenated for 13 minutes before they were intubated. How many of y'all pre-oxygenating for 13 minutes? Yeah, it's crazy, right? And then most of the intubations were done at like 80 seconds. Less than a minute or just over a minute, most of these intubations were completed. Would you expect somebody to start getting hypoxemic on you in 60 seconds or 70 seconds? The answer is no. So this is kind of a silly primary outcome, but this is the study that people quote when they say, I don't do apneic oxygenation. I'm going to take 2 minutes to talk about meds. So first of all, IV fluids. So the PREPARE and the PREPARE 2 trial were published. And basically, they looked at in patients in the ICU that were getting ready to intubate, if we give 500 mLs of fluid versus nothing, do we kind of prevent the patient from crumping, crashing, cardiovascular collapse? And what they found is the answer is no, fluids didn't make a difference. Be very careful extrapolating both these studies to the emergency department and the pre-hospital worlds, because oftentimes those patients are volume depleted and will actually benefit from 500 to 1,000 mLs of fluid. By the time they get up to the ICU, we have flogged them so much, and then our intensivist friends start yelling at us about how much fluids we gave, but they're probably no longer fluid responsive at that point, right? At that point, you got to be thinking inotropes and vasopressors. So again, be careful extrapolating this to the ED and the pre-hospital world. My go-to agent is ketamine. To make this easy, just 2 mg per kg for my shocky patients. I do not reduce dose for shock. I'll explain that in just a second. The reasons I like ketamine is they get a little sympathetic surge, although that doesn't prevent the patient from dropping their blood pressure. It gives you pain control, and it's a nice bronchodilator. Now, there's really 2 paralytic agents to choose from, rocuronium or succinylcholine. One is a defasciculating agent, the other one is not. Again, 2 mg per kg. I like things easy, right? Ketamine, 2 mg per kg. Rock and Sux, 2 mg per kg, right? Just keep it easy. And if you ask me to pick one, it's going to be rocuronium every time. The onset is about the same as succinylcholine at the 2 mg per kilogram dose. The duration is the one thing that it lasts a really long time, 30 to 45 minutes, maybe even out to an hour in a shocky patient. The safe apnea time, this is what I care about, is the patients hold their oxygen saturations up for a longer period of time, from OR studies, at least from anesthesia, when we use rocuronium as opposed to succinylcholine. Now, if you're going to use rocuronium, the thing to remember, the ED awareness study showed us that the number one risk factor of people being paralyzed and not sedated is the use of rocuronium. And so if you're going to use it, you want to order your sedation and analgesia at the same time that you're ordering your RSI meds, so that once you have them intubated and make sure they're hemodynamically neutral or stable, you can go ahead and start that sedation and analgesia. Preventing hypotension, I told you I don't drop the doses of my sedative agent, and this is the reason why. In the ED and pre-hospital worlds, I'll give them fluids, and then if I can, I'll do push dose pressors, but really what I really like to have is a norepi drip up on a pump and ready to go as I'm pushing my RSI meds. If they have a positive shock index or are already hypotensive, I go ahead and start the norepi. If not, it's already programmed and ready to go so that if they do become hypotensive, I can just turn it on. And now I don't have to worry about dropping the dose of my induction agent. Stop laying patients down flat when you're going to intubate them, okay? If you've ever seen somebody in respiratory distress, the natural position of comfort is they want to sit up. They don't want to lay down. It takes extra weight off the diaphragm, allows for better ventilation and oxygenation. It helps you recruit posterior alveoli, which is where the largest surface area of the lungs are. It uses gravity to prevent nausea and vomiting, and you just simply get a better view of the cords. This is now an older study from anesthesia looking at backup head elevated, which is 30 to 45 degrees versus laying the patient supine. 528 intubations. Their primary outcome was a composite of any one of these. We can all agree these are all bad things if you're doing an intubation. And what they ended up finding is just simply the maneuver of sitting a patient up, you have a number needed to treat of 8 in reducing complications. So not only are there physiologic benefits, you also reduce complications by this one simple maneuver. So this is the first part. This is just preparation, right? We haven't even gotten to the intubation yet. We'll get there when we get to parts 2 and part 3. This is my workflow and what I do based on the best available evidence for MicroSkills of preparation. Thank you, guys.